Good evening, everybody. My name is Daniel Southern. The name of my clinic is Interventional Orthopedics CT, and I am the only Regenexx affiliate in Connecticut. For those of you who don't know, and for a quick review, Regenexx in 2005 were the first doctors on earth to begin treating orthopedic conditions using precise stem cell injections. Regenexx has pioneered a new field of medicine called interventional orthopedics. What is interventional orthopedics? Well, the core tenets of this new specialty are that we use injectates, meaning the stuff we inject, that can facilitate healing of bone, tendon, ligament, muscle, or cartilage. The key to this field is precise placement of these injectates into damaged tissues using advanced imaging guidance. And we are committed to the development of new tools to facilitate percutaneous, meaning across the skin, tissue manipulation, because we use only needles. This is not surgery. About 95% of physicians in the United States today can do simple injections, and these are mostly of medications. With special training, 4% of physicians can get a needle inside of a joint and inject a joint. But only 1% of physicians in the United States are interventional orthopedics. And interventional orthopedics have very advanced training. These are all the targets that we can inject in a hip, for example. These are all the targets we can inject in a knee. I should say some of the targets we can inject more if we need to. And these are the targets we inject in a shoulder joint. And all of this is designed to forego the need for surgery. What do we treat? We can treat headaches if they are cervicogenic in origin, meaning if they come from a neck issue, a structural neck issue like arthritis or chronically strained muscles or malpositioning of the cervical spine. We treat neck pain, we treat upper back pain, we treat shoulder arthritis, rotator cuff tears, and labral tears, which is what we'll be talking about this evening. We can treat wrist arthritis, low back pain, disc bulges, radiculopathies, hip arthritis and labral tears, knee arthritis, ankle arthritis, elbow arthritis, and on and on. We treat virtually any joint in the body. If it's musculoskeletal and orthopedic, we treat it. Regenexx is not magic, and stem cells aren't magic beings. What this is advanced and precise interventional orthopedics. Regenexx has been doing this longer than anyone else in the US. Regenexx has more published and online registry data than anyone else. Regenexx spends more resources than anyone else, stacking the deck in our patients' favor. Regenexx has more treatment options than anyone else. Bottom line, if you're going to do regenerative orthopedics, you should be doing it with Regenexx. How do I know this? Because I know that I have a better chance of getting into Harvard than being accepted as an affiliate in the Regenexx network. So shoulder pain, alternative to surgical treatment. The shoulder is quite an amazing joint. This is a schematic of the shoulder. The shoulder blade serves as a platform against which the bone of the upper arm articulates. This whole complex, this whole shoulder complex is attached to the entire rest of the human skeleton only via this very small joint called the acromioclavicular joint here. The rest of it floats, and it floats via muscles. The shoulder blade is not attached to the back. This is an axial MRI view of the shoulder. This is the ball joint of the upper arm, and this is the edge of the shoulder blade against which it articulates. The view is kind of like a golf ball on a tee. Here's the ball, here's the tee, and like a golf ball on a tee, it can easily roll off. This design creates tremendous range of motion. It is the most mobile joint in the human body, and it allows for tremendous vasculature that goes through the shoulder joint that creates the amazing human appendage known as the human hand. Ligaments provide stability, but ligaments attach only the bone of the upper arm to the shoulder blade. There are no ligaments attaching the shoulder complex in general to the body, other than at that very small acromioclavicular joint right here. Muscles provide stability, notably the rotator cuff, consisting of 4 muscles: the supraspinatus, the infraspinatus, the teres, and the subscap. It creates this cuff here that pulls the ball of the shoulder down and in, holding it against the edge of the shoulder blade. There are more muscles. In fact, it's all muscles that control and stabilize the platform of the shoulder. These include the trapezius, the rhomboid, the lat, and the neck muscles. The story of the anatomy of the shoulder is a trade-off between this incredible range of motion that the joint has and joint stability. To attain this incredible range of motion, stability just has to be reduced. And this reduction in stability is what increases the shoulder's vulnerability to injury. So you have a shoulder problem, you have an injury, you have shoulder pain. Let's look at the standard treatment of a shoulder injury. Generally, the shoulder hurts, you rest it, put some ice on it, take some Advil. In the majority of cases, if it's not serious, we'll get better just doing that. But let's say it doesn't. You go to the doctor prescribes physical therapy. Now, the majority of the rest of the people who have shoulder pain, it will be solved in physical therapy, and that's lucky. But if not, and your shoulder pain persists, you go back to the doctor orders a steroid injection. You have a steroid injection, and that may or may not help, and it may help for some time, and then the pain comes back. And if it does, you go back to the doctor, and the doctor orders an MRI. Now, if you're standing in an orthopedic surgeon's office, your chance of having surgery goes up 90%. So let's say you have surgery. Surgery can destabilize the joint further. Surgery often leads to more surgery. Let's say you have another surgery. Add some time into that, and pretty soon you're a candidate for a total joint replacement. That is, in general, broad strokes, the standard treatment algorithm for shoulder pain. So what's wrong with the standard shoulder treatment? Well, we've been over this before in previous webinars. Steroid injections, they're just not good for you. They're toxic. They kill the very cells that keep a joint healthy. And so they're ultimately counterproductive. Whatever they give you in the short term, they take away in the long run. And the local anesthetics that we often inject with steroids are even more toxic than the steroids themselves. They kill the cells that live in your cartilage, that live in your bones, your tendons, and your ligaments. So in the long run, like I say, it's working against you. What's wrong with the standard treatment? Surgery. The shoulder joint is notoriously reactive to any intervention. That's well known in the medical profession. Surgery has long recovery times, and surgery comes with considerable risks. Specifically, what's wrong with rotator cuff surgery repair? Well, the re-tear rate is a real problem. Re-tear rates are 1 in 5 overall at 6 months after surgery. And the re-tear rate is directly related to the size of the tear. So if you have a large tear, your chance of re-tearing after surgical repair is increased. Large tears have a 6 in 10 re-tear rate. 1 in 3 tears, that's 30% of tears that are healed, that are repaired surgically, will tear again at 1 year if you're 60 years or older. So this re-tear rate increases as we age. And only 50% of professional athletes return to the same level of play. What's wrong with total joint replacement? Well, there's a lot that's wrong. This is an eye-opening study done by some British doctors led by Dr. Craig. It was published in the British Medical Journal in 2019. They looked at 58,000 joint replacements over 19 years. And what they found was that 4 in 10 joint replacements in patients under 55 years of age will need revision 10 years after the surgery. 1 in 4 will fail if you're younger than 59, and the highest failure rate is within 5 years. Moreover, the rate of serious adverse events approaches 5%, and these are events that require hospitalization. The conclusion of these doctors is to be quoted, and here it is. All patients should be counseled about the risks of serious adverse events. These risks are higher than previously considered, and for some could outweigh any potential benefits. Our findings caution against unchecked expansion of shoulder replacement surgery in both younger and older patients. So, if surgery is not the answer, what do we do? Well, let's go back to what shoulder problems are all about. Shoulder problems are really problems of stability. The commonest shoulder issue, which is impingement leading to rotator cuff tears, results from instability in cuff muscles. Shoulder dislocations are from a loss of stability in the shoulder capsule. Shoulder separations are from a loss of stability in the acromioclavicular joint. Labral tears are from loss of stability in the glenohumeral joint. And shoulder arthritis can be thought of as simply instability plus time. So instability is the common denominator of all shoulder problems. So how do we increase shoulder stability? Well, any joint stability is satisfied in 2 ways. A joint has both dynamic and static stabilizers. The dynamic stabilizers, of course, are your muscles. The static stabilizers are your ligaments. Now, exercise can strengthen muscles. Unfortunately, it cannot strengthen ligaments. How do muscles cause shoulder instability? Well, they become weak, and they become weak with age. They become weak with disuse. They become weak with wear and tear, and they become weak after shoulder injuries. This is why we send you to physical therapy, because therapeutic exercise, without a doubt, will strengthen your muscles. And the whole theory here is that stronger muscles equal greater shoulder stabilization. Ligaments also increase stability, but they also become loose with age, with injury, or with underlying diseases such as Ehlers-Danlos syndrome, which is a problem with connective tissue, making it way too stretchy. Again, exercise will not strengthen ligaments. How do we strengthen ligaments? There's a technique that's been around for about 85 years. It's called prolotherapy. And prolotherapy are injections, and they can be defined as an injection of growth factor or growth factor stimulating injections. And what they do is they address connective tissue insufficiency, which is a very fancy way of saying loose or torn ligaments or tendons. What it does is it tightens up a loose joint. It can require repeat treatments. This is often something that we repeat in regenerative orthopedics to get a joint stable enough. This is a picture of an ultrasound injection, ultrasound guided injection. Here's the needle. This is the ITB band that's being injected. This bright signal is the knee joint. This has been around for 85 years, as I mentioned. We have good scientific bench work that shows that this works. It's the injection of an inflammatory irritant solution into a tendon. This is a tendon here on the left before. And this is it afterward. And you can see how thick the ligament is. Here again, before injection, after prolotherapy. For many decades, we've injected irritant solutions, and primarily that's sugar water, 12.5% dextrose. It's pro-inflammatory. And remember, the body heals itself through inflammation. So if you inject a structure and you cause inflammation in it, it's a beacon to the body that something needs to be repaired, and the body will send repair cells to the area. And this is the result of that repair process. The revolution in Regenexx is that we discovered that if you inject human repair cells instead of just an irritant solution, this works a lot better and it works a lot quicker. Orthobiologic injection. It comes from orthopedics plus biological cells. We refer to our injectates as orthobiologics. Human repair cells come in two flavors: platelets, which is a small cell circulating in the blood, and stem cells, which we get from bone marrow. And these are precise injections into damaged tissues, and that's the key. You have to very precisely inject the damaged areas. You can't just throw it willy-nilly into a joint and assume the cells will find the damage. No, you have to inject the damaged tissue. And what we're doing is we're stimulating an inflammatory repair process. So let's take a 30,000-foot view here. What are we able to do by doing this sort of stuff? Well, we can help people with severe shoulder arthritis. We can help folks with rotator cuff tears, and we can help them with shoulder labral tears, amongst other things. But we're going to discuss basically these three diagnoses tonight. Shoulder arthritis. I often get asked, what is arthritis? Well, arthritis begins in the cartilage, which is the articular surface of any joint. And once the cartilage is breached, it progresses to bone, and bone becomes involved. And that's usually when the pain starts, is when the bone becomes involved. What drives arthritis? Well, instability more than anything else. Abnormal loading of a joint will increase degeneration in the joint and lead to arthritis. Age, simply getting older, leads to arthritis. Trauma to the joint, and surprisingly enough, surgery. Any surgery in a joint increases the chances for arthritis in that joint. Now, there's no cure for osteoarthritis, but orthobiologics can decrease pain, improve function, and slow down the rapid progression of osteoarthritis. So instead of joint replacement for arthritis, we inject high-dose stem cells precisely into joints, the bone, the labrum, and the ligaments of the shoulder using ultrasound and real-time X-ray guidance. Who's a good candidate? Well, we keep a registry of outcome data on all of the patients that we do in Regenexx. We rely on patients to upload, a questionnaire on how they're doing at various intervals after we do procedures on them. And it's from this data that we've gleaned who's a good candidate, who's not. And we classify them basically into three categories: poor, fair, and good. If you're placed in the poor category, we think you have a less than 30% chance of success, and we basically tell you that you probably need a joint replacement. If you fall into the fair category, we think your chances of success are 30 to 60%. In the good category, we think your chances are greater than 60% for a successful outcome. And what is success? Well, our patients define that. They come walking through the door and they say things like, "Doc, all I want to do is play 18 holes. And if I can get back to doing that, I will be thrilled." And so that's success for that patient. How well does this work? Well, this is right off the Regenexx website. This shows patients treated for arthritis in the shoulder, and this is a graph of overall improvement. Down here, we have months, time since injection. Here we have percentages of improvement. And as you see, it's quite a good curve. And now going out 4 years, an average rating of improvement is 71% compared to where they were before the procedure. These are smaller graphs of decrease in pain and increase in function. This is a study of 199 patients collected from 14 Regenexx clinics. This goes back to 2014 when we published this. Basically, once again, it shows time from procedure here and percentages of improvement. And these are improvements in pain, improvements in function, and overall improvements in the pale blue. And again, this is going out this is going out 2 years. This is a case history. And this is a candidate that came into my office this past year, as a matter of fact. And I selected this one simply because this patient was a 50-year-old male, self-described. He was an avid weightlifter, and that's all he wanted to continue doing. He had a past medical history of right shoulder dislocation, such that if he slouched down in a chair and nodded off and fell asleep, this position would cause subluxation and dislocation, and he would wake in tremendous pain. So there were certain positions he just needed to avoid. These are his x-rays. Let's go back here. These are his x-rays. And these show without a doubt that this gentleman is a poor candidate for what we do. He and was told this, you know, that you are not a good candidate. You really shouldn't consider this. When you're ready, you should have a joint replacement. You can see this large beard osteophyte here, the narrowing in the joint space. Those two things alone throw him out. There's also a very faint circle here. This is a large bone lesion. The cartilage is completely destroyed, and now the bone is deeply involved. All of this made him a very poor candidate. But he was insistent. He knew going in his chances were less than 30%. He said, I want to try it because I don't want to have surgery, because he knew that surgery, he wouldn't be able to continue lifting weights if he had a total joint replacement. So we treated him with his own bone marrow. We focused on the shoulder ligaments because I thought the best I could do was really get this very unstable shoulder just a little bit more stable. But we also did a bone augmentation procedure shown here on the right. This is an 18-gauge trocar going into the bone to treat this ugly lesion here seen on MRI. This is a bone lesion. And whatever else is going on inside here, we know that the stem cells that are in this bone natively are dead, dying, and not functioning. So we went into the bone and delivered fresh, healthy stem cells from his hip bone. This is a real-time ultrasound injection of the shoulder. This is the shoulder, this line going over. This is the labrum, this little triangle, and this is the needle going into the shoulder joint. And you'll see in just a second here, the bone marrow lights up the capsule right there. So what was the outcome? Well, this is my clinical note. At 4 weeks after doing this, and I quote, he states that the deep ache in the shoulder is gone. He reports that at soccer practice as a coach, the shoulder catches and clunks a bit as before. But in general, he states that his range of motion is improved. He states that the improvement is such that if this is the new baseline, I am more than happy and can live with this. Now, this patient is an advanced responder. Our registry data tells us that generally the first response after doing bone marrow is 8 to 12 weeks post-procedure, because we know that the final phase of repair is the remodeling phase, and that's when the tissues that are regenerated in a damaged joint are strengthened through maturation. This continues for 17 to 24 months, so up to 2 years after we do this type of procedure. So here's a guy who beat the odds. He was a poor candidate. We told him so, but he insisted. We did it, and he had a good outcome. Rotator cuff repair. The rotator cuff, again, are these four muscles here, the supraspinatus, the infraspinatus, the teres, and the subscap. And what they do is they pull the bone of the shoulder down and in. And what that does is it increases the gap between this bone and the top of the shoulder. And that prevents impingement, so that when you're reaching up with the arm, you're not slamming the rotator cuff up here. This is a side view of it. This is the rotator cuff. And if the rotator cuff muscles are weak and not doing their job, the shoulder ball joint will ride up and hit this bone here and impinge. And over time, impingements can lead to tearing in the cuff, generally in the supraspinatus right here. This is an ultrasound view of the supraspinatus. Here is the shoulder bone. This is the supraspinatus. We call this the bird's beak because it looks like an eagle's beak. This is a cross-sectional view of the same ligament, the supraspinatus. Again, this is the bone. And if you look closely, you can see inside the tendon this jagged sort of dark space. That's the tear. You can see it on the cross view over here. It's quite large. So what's the treatment for this? Well, under ultrasound view like this, we come in with a needle right into the tear, and we inject it with bone marrow. So instead of surgery, we inject high-dose stem cells precisely into the tears under ultrasound guidance. Who's a good candidate? Patients with partial to full thickness tears without retraction. If you're fully torn and retracted, we can't help you. It's a surgical case. This is a good candidate here. You can see that this is a small tear. This is a poor candidate. You can see it's a large tear. We can see one end here, the other end here, one end here, the other end here. These people we turn away. We tell them that they're poor candidates. They should probably have a surgical repair. This is the ultrasound. Injection here is the supraspinatus tendon. This is the shoulder bone. This is the needle coming in and injecting it. This highlight is the injectate we're putting into the tendon. So what's the data on this? Well, we published a large case series showing positive outcomes in the Journal of Pain in 2015. And we're currently in the midst of a randomized clinical trial, which is the highest scientific evidence that we have. And halfway through it, we are randomizing patients with rotator cuff tears to either exercise, represented by the blue line here, or to percutaneous injection of stem cells. And what we're seeing here is improvement in DASH scores, which is a disability of the shoulder index. And as they go down, this represents improvement. And as you see 1 year post, there's a very significant difference between those injected with stem cells and those who just had exercise. This is a dramatic before and after. This is the before picture, and you can see there's a large full thickness tear here. And this is the after view, and you can see up here that there is continuous tendon going across. This is another before, again, a dramatic before and after. You see two ends of the tendon separated here, and here you see them repaired going all the way across. Labral tear repairs. The shoulder labrum. This is that axial MRI, and this is the round bone of the shoulder. And again, this is the flat edge of the shoulder blade against which it articulates. The labrum is this little triangular extension of soft tissue there and here. These two little triangles. Well, I'm keeping the triangles. Here they are. The labrum is the purpose of it is to deepen the articular surface of the flat bone so that it can provide stability to the ball joint as it articulates. But just like that image of a golf ball on a tee, it's easy for the ball joint to slide right off, either front or back, off of the glenoid, the bone against which it articulates. And the labrum can be injured in dislocations, either forward or back. It can tear the soft tissue here and here. Or just over time, if this bone, the round bone of the upper arm, moves too much, it can repeatedly slam and bump against the labrum front and back, and it can tear it. The commonest tear in the labrum is called the superior labrum anterior posterior, or SLAP tear. And there are 4 types of SLAP tear. Who's a good candidate for this type of repair that we do? Well, SLAP tears type 1 and 2, tears that are just frayed or frankly detached. But when we get into the bucket handle tears, where you get a flap folding down in the shoulder, we don't do so well with those. You're a poor candidate if you have that type of tear. This is an anterior labral tear on the left here. This is normal, healthy labrum. Over here, you can see that there's a tear here in the anterior labrum. This is something we can repair. This is a guided real-time fluoroscopic view of a needle coming in. You can see the needle here. And its first placement is into the joint, and you see that dark flow of dye right there. But then the needle is withdrawn and directed up towards the labrum. And that little shadow coming in here, that little triangular shadow, that's the labrum. Right there. So you see the precision with which we have to deliver stem cells to get a repair process. This just illustrates that. So interventional orthopedic approach to shoulder pain. The take-homes are that we preserve native shoulder structure and tissues. We don't remove anything. We're trying to repair tissues that are torn and damaged. We treat shoulder instability. That is key for virtually every shoulder problem that there is. The shoulder's unstable and it needs to be made more stable. And we can definitely do that. We do that through a technique called prolotherapy. We use the body's ability to heal itself. And this is not surgery. We're using only needles through the skin. To end, I'd like to discuss what we have done to the standard algorithm. This is the algorithm we discussed at the beginning of the presentation. It's pretty much the same up until we get to an MRI. When you get to the MRI, the decision point there is, do we do surgery or do we not do surgery? Well, with interventional orthopedics, we don't have to do surgery anymore. We can do an orthobiologic injection into the shoulder, very precisely placed, with your stem cells, send you back to rehabilitation, physical therapy. And if we're successful, what we've done is we've preserved your native tissues, we've repaired your native tissues, and most importantly, we've taken you out of the algorithm that pushes you inexorably towards surgery and to joint replacement. That concludes the presentation. And I want to thank each and every one of you for coming out on a cold night and listening to the webinar. I will end by posting my resume and take any questions that anybody has. We have a question from Carmelita. Carmelita Rifkin, are you there? Can you hear me? Well, Carmelita asks, how do you decide between PRP and stem cell for a tear in the rotator cuff? But the answer to that is, small tears can be repaired with high-dose platelets if it's a small tear. If it's a big tear, you've got to go with stem cells. What's a big tear? Anything over a couple of millimeters is going to require stem cells. Short of that, we could go with high-dose platelets, and that's a discussion to be had in office. Carmelita's next question was, can stem cell help regrow a muscle in the cuff that is retracted? No, it cannot. That makes you a poor candidate. If you've torn muscle and the muscle is retracted, then if it's going to be repaired at all, it's going to require surgery. I'm clicking on answer live. Robert, are you there? You had a question here? Can you answer, or can you want to say hello? No, you haven't answered. Okay. Robert's question is, how many injections do you do into a joint, and how many times is this protocol performed? We tend to go with stem cells once, Robert. We may do repeat treatments of prolotherapy into the ligaments to stabilize them and make them stronger. But we often do that just with platelets. We go into them, one time if I have to do anything else, like repair a labrum or do a bone augmentation with stem cells, and I'll treat the ligaments with stem cells at the same time. But if I feel that it needs more stabilization, we'll treat the ligaments more than once, maybe once, twice, maybe 3 times, depending on how bad the shoulder is, with just platelets. How many injections do you do? Well, I hope that answers it. Often patients will ask me just before we're about to begin a procedure, they say, well, doc, how many times are you going to inject me? And if they ask me that, I know that I failed in conveying what it is I'm doing. We don't count the number of injections during a treatment, but I got to tell you, it's quite a few. We have to move the needle through the skin to get to various targets. So it's multiple injections per treatment. I'm sorry, I don't know why I can't allow you all to speak and we can have a real-time discussion, but I don't seem to be successful with that. Sophia had a question. Can old injuries be repaired? Yes, they can. The dividing line on a rotator cuff tear, for example, is if it's, frayed to the point where it's finally completely torn and then retracted, no, I can't help you. But, chronic tears over time, sure. We can get in and inject powerful repair cells in the form of your stem cells. And we can actually get some reorganization of scar tissue. We can't make the scar tissue go away entirely, but we can get it to reorganize and we can get some new healthy tissue to overlie the scar tissue. So yes, the answer is we can treat old injuries going back, many years, a decade and more. The gentleman I showed you earlier, his shoulder, he'd been having issues for 15, 20 years and had a satisfactory outcome. Michelle, these concepts can be applied to any joint. Yes, that is correct. Michelle, again, where are your offices? We're located here in Norwalk, Connecticut, and you can find me online through Regenexx.com. If you can't find me there, come right to my website, which is IOCT.info. IOCT.info, down here at the bottom of my bio. Does insurance cover any of these procedures? The way my practice works is we will see you under your insurance. We will evaluate you under your insurance. If you've had none of the traditional treatments we will do them under your insurance. In other words, we will treat you in the way you would be treated in an orthopedic surgeon's office before he decided to take you to surgery. At that point, that's when we say to you, well, hey, we have a better widget than surgery. This is what we do. It's at that point that we leave the insurance model. At that point, the procedures that I do are all, not reimbursed by insurances. And what we typically do is we send you a treatment proposal, which breaks down the cost. And if you have any further questions, then we discuss, before you agree to move forward. There's no arm twisting here. We're medical doctors, we're not salespeople. So that's generally how it works. If you come in and you want a steroid injection, I'll do one steroid injection for you under your insurance, and your insurance will pay for that. I won't do repeated steroid injections because I know that's not good for your shoulder. I hope that answers your question. Mary Ann had a question. How do you obtain the stem cells? We get stem cells from our patients. We can get them from any bone in the body. We tend to get them, we do get them from the large hip bones. If you reach around behind you, just above your butt, there's two bony prominences. These are called the iliac crests. That's where we get your bone marrow. They're very thick bones. They have a lot of marrow. There's no major nerves or blood vessels back there, so it's safe to do and to get them from there. That's where we get them. Carmelita had a question. Carmelita tried to answer, but it's not working. Yeah, I know it's not working. I'm sorry. Anonymous attendee, how and where are stem cells harvested? I hope I just explained that. The stem cell procedure is a 3-step procedure. It's 3 steps done over the course of a week, roughly. We use a Monday, Wednesday, Friday time frame. On Mondays is a quick pre-injection. It's where we inject the good old standard prolotherapy solution of irritation, 12.5% dextrose, which is sugar water, just to get a little bit of inflammation going in the joint. It takes about 5 minutes under ultrasound, and that's all we do. 2 days later is the big day, say on a Wednesday. It doesn't have to be Monday, Wednesday, Friday. We just use that for illustration purposes. Wednesday is the big day. That's when we harvest your bone marrow. That takes the better part of an hour, about 45 minutes to do. Then we collect all the stem cells in our laboratory from that bone marrow, and that takes a long time. It takes about an hour and a half to do that. And then it'll take the better part of an hour to, put the stem cells back into the joint we're treating. So that day, you're with us about 4 hours. 2 days after that, on a Friday, we do the post-injection. You come into the office, we take some blood from a vein in your arm, capture all the platelets, quickly go back into the joint and just deliver platelets. We're in essence, what we're doing there is we're feeding the stem cells that we placed earlier. This is how we grow stem cells in the lab. We feed them with platelets. We grow them in platelet lysate, which is a special preparation of your platelets. So it's a 3-step process. The big day is the re-injection on the middle day. That's where we harvest the marrow, put the marrow back in the joint, but there's a pre and a post injection. I hope that answers or makes it a little more clear. How do you obtain the platelets? Marianne asks. That's a simple blood draw. We just, it's like giving blood or having labs taken. They draw some blood and run some labs on your blood. Robert had a question. How long does physical therapy last after injections? We're doing bone marrow. We don't start physical therapy for at least 4 weeks. There's no rush to it. And then physical therapy will go for at least 4, 6, 8 weeks after we do this. And that's, once again, to work on the dynamic stabilizers after I've done extensive amount of work injecting your static stabilizers, your ligaments with the stem cells. So it's a 1-2 punch on stabilization in any joint. Physical therapy is very key. We don't do these procedures without follow-up physical therapy. So that's very, very important. And it goes for a couple of months after we do it. Sophia had a question. Does harvesting stem cells cause side effects? No. It's very, very safe. And the corollary question to that is it painful? No, it's not painful. If you know how to take the time, which we do, to numb up the area. And the real key to getting bone marrow is numbing up the cortical bone that we go through. If you numb up the cortical bone, you can go through it with a needle to get the marrow easily. It's not painful at all. You feel some pressure, but it's not painful. Side effects, anytime we do any of this, the main risk of what we're doing is that of infection. Can you get an infection by us going into your bone marrow? Sure you can, but we do these under sterile operating room conditions, with full mask, gown, the whole bit. You're fully draped. We do our best to avoid infections. But that would be the biggest risk. Side effects, you're going to be sore after I, draw bone marrow from those bones, but that's the least of it, and that's gone within 3 to 5 days or virtually gone, and you heal it very fast. Ruth had a question. How effective is stem cells with CRIPS? Chronic regional pain syndrome. We can be effective with chronic regional pain syndrome if it's a neuropathic chronic regional pain syndrome. And if that is the case, then we identify the nerve and we do what's called a hydrodissection of the nerve with platelets and or stem cells. And the reason we do that is because these repair cells have powerful repair hormones, some of which are neurotrophic, meaning they're very specific to nerves that have been damaged. And so bathing these nerves in these repair cells can help the nerve to heal. So yeah, we can be effective in certain forms of chronic regional pain syndrome, those that are considered to be neuropathic in origin. Question from Anonymous. There seems to be different approaches to PRP. How is yours different? That's a whole lecture. It's a whole lecture. Nobody processes platelets like Regenexx. Every Regenexx affiliate has a laboratory. Everybody else in the field who is doing this type of PRP work has attended a weekend course, and they've purchased themselves a little bedside centrifuge, and then they buy kits from the manufacturer. Well, the kits are all, because they don't have laboratory, they have to buy kits. The kits are all designed to draw blood so that it never hits the open air, that it stays fully contained within the kit from vial to vial. It's then thrown into the centrifuge and processed, pulled out of the centrifuge in the tube as platelet-rich plasma, and then injected. This limits you in 2 ways: the amount that you can get and the concentration you can get. With a bedside centrifuge, you can concentrate 7 times baseline. With an independent laboratory, like all Regenexx affiliates have, we can concentrate platelets any concentration we want. If doc says he needs 20 times baseline, I can get 20 times concentration baseline. All I have to do is tell my lab technician. That's because we do this by hand under a sterile hood. The laboratory technician reaches into a sterile hood, which has a negative pressure environment so that there's no bugs or bacteria floating in the air, and they can process the blood by hand. Because we can manipulate it by hand, we can get any concentration we want. Because we manipulate it by hand, we can get rid of all the red blood cells. This is another downfall of the bedside centrifuge kit system. They can't get rid of red blood cells, not all of them. That's why their PRP tends to look rather bloody. And you don't want red blood cells in a joint. Ask any hemophiliac. These folks, unfortunately, bleed into their joints. It destroys their joints. So red blood cells are a no-go. And when we process PRP by hand, we make sure there's no red blood cells there. I hope that answers your question. Kathy has a question. Can these protocols work for a bone-on-bone situation in a knee? Yes, and that term bone-on-bone is really thrown around quite loosely, particularly in orthopedic surgeons' offices. And it doesn't mean a whole lot. You know, bone-on-bone on an x-ray, you know, you can make anybody look bone-on-bone with an x-ray just depending on the angle of which you take the picture. So the real determinant is the MRI. An orthopedic surgeon doesn't want an MRI of your knee necessarily, particularly if it's bone-on-bone arthritis, because they're going to amputate that joint for you. So they don't care what it looks like under MRI. They've seen the x-ray, it's bone-on-bone, we're going to amputate it, give you a new joint. Well, that's not the way it works in the Regenexx world. We always get the MRI. And the MRI shows us, without a doubt, how badly, you know, frayed and torn and missing is the cartilage. And more importantly, how much is the bone involved? Because the bone can be involved and you won't see it on an x-ray. An MRI, however, will show swelling and edema in a bone, subchondral. And if we see that, then we know we have to do a subchondral bone augmentation. So, you know, bone on bone, we have criteria for who's a good candidate. If you're bone on bone, that doesn't mean you're a bad candidate. If you're bone slipping off bone and you're that unstable, you're a poor candidate. But bone on bone, no, you know, that, especially that term, it doesn't make me think, oh no, you're no good. I need to see your films. I need to examine you. And then I'll tell you if I think that we can help you or not. Sophia had a question. How does the cost of treatment compare to cost of surgery? Well, that's a good question. Particularly with joint replacement, if you're going to have your joint replaced, even when insurance covers this, the out-of-pocket cost, given your deductible, et cetera, is right on par with what we charge for a stem cell procedure. So the cost is not that different ultimately. Ruth had a question. Is stem cell injection painful? You know, the painful part really is just going through the skin. When we do bone augmentations, yes, they're painful. We can get into the bone with a trocar and a needle. We can pull bone marrow out of a bone. It's not painful. But when we go into a bone and then inject stem cells into that bone, yeah, that's painful. Robert had a question. To expand on my question, after my procedure in December, how many weeks will I be doing therapy, which seems to be helping greatly? Well, like I said, Robert, 4 to 6 weeks, maybe as much as 8 weeks. Tom had a question. What is the best PT for torn supraspinatus in advance of stem cell procedure? Tom, that's bread and butter physical therapy. That's therapeutic exercise for the rotator cuff. Those are, you know, standard motions and exercises. And depending on how badly the cuff is torn, you don't want to do these exercises and increase pain. If you're increasing pain by doing the exercises, you may be causing more damage. But you can still do exercises that are isometric, where you're not moving the shoulder at all, and those can be helpful. So strengthening the rotator cuff as much as you can before we do a stem cell procedure, really a great idea, because we're going to send you back to physical therapy after we put in the stem cells and strengthen it some more. Carmelita had a question. Is the patient awake for PRP? What meds are given pre-treatment? That's your choice. And in my clinic, we do have an option to take you to a fully staffed ambulatory surgery center where you will receive IV sedation. Be aware that adds cost to the procedure because your insurance won't cover that facility. In office, we tend to do oral sedation, which is a benzodiazepine Valium type drug mixed with another one. And we'll even give you some oral pain medication. And then while we're working, we're injecting local anesthetic as we work. So you don't necessarily have to be awake for PRP if you don't want to be, but it's not a terribly painful procedure if you wish to remain awake. Robert had a question. Out of pocket for a joint is around how much in cost? Ballpark, Bob, stem cell procedures start around $5,000. PRP injections start around $1,500. And that's ballpark. And it all depends on, you know, how many things I have to treat, how much blood and bone marrow I need, and what I have to do. Ruth, are you able to draw blood for PRP via a portacat? You know, we don't like to do that because the oncologist and the people who are using the portacat, they don't take kindly to somebody like me coming in and using a portacat. If we have to and we get permission to, certainly, yeah, that makes it easy, actually. Tom had a question. Oh, no question. Richard had a question. How effective is stem cell on stenosis in the cervical spine? Well, Richard, you know, all I can tell you is that I have a number of patients I take care of, and they have stenosis in the cervical spine, amongst other things, bad arthritis and instability. And we treat them, you know, periodically with platelet lysate and highly concentrated platelets, or if they choose, stem cells into the facet joints only. We don't ever inject over nerves with stem cells or in the epidural space with stem cells. But I have lots of patients with stenosis in the lumbar spine that we treat with platelet lysate injections, and they come back semi-regularly for them, and it keeps them going, and they get to avoid the dreaded fusion, lumbar spine fusion surgery. And this is a tough question to answer. There are some forms of stenosis. If I look at on film, I'll tell you right up front, I don't think I can help you. And others, it's the majority are the others that we can help with semi-regular treatments, keeping you going in time. I'm a case in point. I have a chronic right L5 sciatica, and I've had 2 platelet lysate epidurals, but I haven't had one for 3 going on 4 years now. I'm good. When I feel I'm not good, I'll go back and have another one. Question from Anonymous. What is your rate of success for good candidate procedures? Well, like I say, based on our data, our rate roughly is 60%. So that's pretty darn good if you consider that chance is 50-50. So, you know, around 60%. I think that's everybody. Anybody else with a question? I'm sorry we couldn't let you talk. I'm sorry I couldn't figure out how to do that. Looks like I've run through all the questions. All right. We'll give it another minute if anybody can think of something they want to ask. Sophia did have one question here. How long should you not exercise after a procedure? It really depends on what it is we're doing and what joint we're treating and what kind of exercise you want to do. We understand how important exercise is, and there's always exercise that you can do depending on what we've done, what your problem is, how unstable I think your joint is. The short, simple answer to that is you can swim all you like. Swimming is a form of exercise that virtually every procedure we do can do almost immediately following. Almost immediately. We create, you know, channels, especially into the bone marrow. We don't want you in a pool or any submersing in water for at least 72 hours. But beyond that, yeah, you can jump in a pool. And there's low impact aerobics. Typically, we can do those depending on what body part we've treated. You can even resume weightlifting. It all depends on what we've treated and how bad it is. And So I have to answer that question in the clinic. Robert had one more question. I'm interested in having my knees get some type of treatment in the future. I just had my last gel injections. What do you think of those? Well, that's a good question. When I was a fellow at the Hospital for Special Surgery, the first clinical trials on hyaluronic acid, which are the gel injections, as you call them, first came out, and it was eye-opening. It was like, oh my gosh, this could be the answer, right? We thought, those of us who were in the field, that this could be the best thing since sliced white bread. Didn't turn out that way. And subsequent trials, good ones, large trials, have shown there is no difference between gel injections and injecting normal saline, which is water. The American Association of Orthopedic Surgeons no longer recommends gel injections, and that's listed prominently on their website for the treatment of osteoarthritis. We no longer recommend hyaluronic acid injections. So I don't do it. I'm not interested in it. The good thing about hyaluronic acid is it won't hurt your knee like a steroid injection can. And some patients do swear by it. I'm aware of that. But, the mega data says it doesn't work. Therefore, we don't do it. All right. I think that's going to conclude our webinar. Once again, for anybody else still on and listening, thank you very much for coming. Be safe, be well.